In this presentation, I'm going to be talking about anxiety and stress disorders. So the first thing that I'll cover is anxiety, obsessive compulsive, and stress disorders. So I'll specifically talk about the symptoms outlined in DSM-5, as well as prevalence and comorbidity. Then I'll move over into the physiological involvement. So what parts of the body are involved when it comes to anxiety, specifically with stress. Then I'll cover the physiological impact of these different disorders on the brain, on the body. Um, so I'll outline like neurobiological alterations in that section. And then I'll cover treatments and what we can take, what's the takeaway from this presentation. So when we think about anxiety and fear, um, they're part of our emotions, right? Um, as graduate student, that is me, I am a graduate student. There are instances when I do feel really anxious and really fearful about a lot of different things. And it might be related to a presentation to do. It might be related to research. It might be related to, it might be related to teaching or all the above, or even therapy. So when it comes to anxiety, depending upon the stressors that we face, it's normal. I say normal, but it's appropriate. It's adaptive. Uh, However, when it becomes concerning is when it's very persistent and it's in excess. And there's also uh, specific behavioral disturbances that accompany it. So with anxiety and obsessive compulsive disorders, they're characterized by, you guessed it, anxiousness, specifically extreme anxiousness, and to some extent, extreme and persistent fear. So I'm going to talk about these different disorders, uh, starting with generalized anxiety disorder. So generalized anxiety disorder, this is characterized by persistent worry and anxiousness. This specific disorder, the anxiety isn't tied to a specific thing. It's to a wide variety of things. It's quote unquote free floating. It's also characterized by some physiological symptoms. So a person may experience muscle tension. They may experience fatigue. They may have some sleep problems. So they may have trouble getting themselves to sleep. In some instances, there's some sweating, heart palpitations as well. When it comes to generalized anxiety disorder, um, it occurs more so in women than men, and 0.9% of adolescents and 2.9% in the general population. It is also comorbid with other psychological disorders, such as anxiety disorders, and in some instances, substance use disorders. Social anxiety disorders, or to some social phobia, this is where a person has persistent fear or anxiousness or both about social interactions and situations that involve some possible evaluation. So the person might be afraid of being embarrassed, humiliated, or even rejected or offending other people. So it's important to note that um, uh, social anxiety disorder is completely different from being shy. So if you're just like, oh, I'm not, I'm not a big fan of being around people. I don't like to talk that much, but it doesn't make you nervous to talk to people. Um, and when I mean nervous, I mean like you're not having these heart palpitations when you're talking with people, then that's, that's definitely not social anxiety disorder. Um, Social anxiety disorder is someone experiencing like these, experiencing like this excess and persistent um, fear or anxiety around these social situations. So a person might actually do their best to avoid uh, these situations. It is one of the more common types of anxiety disorders. It impacts 7.7% of the general population, and it is higher in men. And it has been found to be comorbid with other anxiety disorders, as well as other psychological disorders such as depression, bipolar disorder, and even in some instances, body dysmorphic disorder. So I found that really interesting. Phobia or a specific phobia, this is basically where a person has fearful or anxious anxiety about a certain object or situation, and they tend to avoid it. So I, as much as I identify, uh, very kindly with creatures since I am a vegan. I still struggle with cockroaches that fly. They scare me. To me, it just doesn't make sense that a cockroach can fly into my face. Um, However, I'm not, uh, if I hear the word cockroach and I hear the word fly or flying cockroaches, or if I see one or if I see a picture of one, um, I'm not going to run at the room screaming. Now, if it flies on me, I will, but for someone who has a phobia of flying cockroaches, the word will elicit a strong reaction from that person. They might even do their best to make sure that their environment is free from uh, flying cockroaches. And if you live out in the country, that is really, really hard to do. Um, so yeah, just throwing that out there. With specific phobia, it is also one of the more common forms of anxiety disorders, 7 to 9% in adults, and it's tend to be reported more so in men compared to women. It's also comorbid with other anxiety disorders, such as panic disorder, for example. Also, also comorbid with substance use disorders as well as depression. So I talked about panic disorder a minute ago, and panic disorder is where a person has an extreme or excess concern around having a panic attack, and there's also some behavioral changes. So with a panic attack, um, this is where a person experiences heart palpitation, sweating, trembling. Some people report uh, feeling like they're choking. Other people also report that they feel like they're having a heart attack, that they're going to die. Um, so that's the panic attack has to be there um, for it to be classified as panic disorder. It has to, the concerns and the changes, the behavioral changes have to be 1 month after the panic attack. There is a specifier or specifiers. So there's expected and unexpected. So expected is in response to a feared object or situation. So going back to the person that was afraid of flying cockroaches, they're more likely, if they experience a panic attack um, in response to that cockroach, then boom, there is a specifier, expected. Unexpected is when the panic attacks occur for no reason, um, in this case. With panic attacks, with panic disorder, 2 to 3% of adults and adolescents, and it is comorbid with other psychological disorders, specifically other anxiety disorders, depressive and bipolar disorder, and also some mild alcohol use. It's also important to note that it can be related to a physical health condition. So, for example, hyperthyroidism. Uh, Basically, there's overactivity in the thyroid, um, and this can elicit panic attacks. Um, so, just something to be mindful of when we think about folks who report having panic attacks and who show the symptoms of panic disorder, making sure that we're getting a full picture of them when it comes to their physical health, because it could be an underlying physical concern. Obsessive compulsive disorder. So this is characterized by obsessions and compulsions. So obsessions are these reoccurrent and persistent urges, images, and thoughts, whereas compulsions are repetitive behaviors, are acts that are driven in response to an obsession. The DSM also talks about there being some very rigid rules. It's also suggested, I say suggested, but a person can have obsessions, compulsions, or both, to be clear. OCD is one of the rare forms of anxiety disorder, coming in at about a prevalence rate of 1.2%. It is comorbid with other psychological concerns, such as other anxiety disorders and depressive and bipolar disorder. So taken together, when we're looking at these anxiety and obsessive compulsive disorders, right, the main character or the main feeling is anxiety and to some extent fear. So PTSD. PTSD is characterized by um, different different symptoms. So with PTSD, not only do you see um, the extreme stress and anxiety, you also see some hyperarousal and hypervigilance. So a person is so basically a person is like on 10, they're tense, um, and they're basically like ready for I say ready for anything, but their body is responding in that way. So they tend to be a little bit more on guard. There's also the reoccurring memories and dreams around a specific event. We're going to talk about that in a little minute. And then we also see some difficulty motion. So while we do see anxiety, we also see some fear. And to some extent, for some folks, they do report some feelings of depression as well. We also see isolation and avoidant behaviors. Specifically, when it comes to the avoidant behaviors, this is avoiding the trauma-related stimuli. We also see the development of these these symptoms after a life-threatening experience. So this life-threatening experience may be actual or threatened death, serious injury, or even sexual violence. Oops, let me go back. Sorry about that. So PTSD, it's important to note that a person who experiences a life-threatening event or these different traumatic events, um, they don't always develop symptoms of PTSD. Well, they develop symptoms, but these symptoms don't progress into what would be diagnosed with PTSD. Um, so I'd want to be clear about that because at about 3.5% of folks have are diagnosed with PTSD or have the disorder, we do see it's higher among veterans, specifically those who have seen combat. Also higher amongst people whose profession calls for being placed in situations where there is actual or threatened death. We've also seen it higher amongst survivors of rape as well. And it is comorbid with other psychological disorders, such as other anxiety disorders and depressive disorders as well. We've also seen it be comorbid with substance use disorders. So before I move forward, I do want to talk about the stress response because it is the physiological involvement. So what's implicated in the stress response is the nervous system, specifically the autonomic nervous system. So the autonomic nervous system controls automatic processes in our bodies. Of note, we're going to talk about the sympathetic nervous system. This is the system that arouses the body when a person is faced with a stressor. Throughout the sympathetic nervous system, or specifically throughout our body, we have the dispersion of epinephrine. Epinephrine, in this case, is a hormone, and it prepares our body for the surge of energy as well. We also see the dispersion of norepinephrine, and norepinephrine as a hormone activates organs that are needed for actions, or organs that would be helpful for that action as well. So with the sympathetic nervous system, it helps us get our bodies ready to either fight the stressor or flee the stressor. So in the event, like my apartment is like on fire, right? What's going to happen is my brain, I'm going to perceive this as a stress. I would hope so. Other than that, if I didn't, I'd be burning. But I'll perceive this as a stressor, and we'll talk about the parts of the brain that are involved in it. But what's going to end up happening is I'm going to experience the surge of energy, and epinephrine is going to arouse my body, and norepinephrine is going to activate organs that are very helpful in this case. So thinking about my legs, my heart, right? I'm going to need that, but not so much my stomach, because it's important for me to like flee the stressor instead of digest that vegan brownie. The HPA axis is really important when it comes to stress response. So I mentioned the brain. This is specifically what I'm talking about, the hypothalamus in particular. So before I move into that, the HPA axis, just very broadly, is this neuroendocrine system that is really important for regulating that stress response. So I mentioned the hypothalamus. It's located below the thalamus, hence hypothalamus. Yes. And it's associated with homeostasis. So keeping our bodies, or I say keeping our bodies, but having our bodies regulate temperature, regulates the endocrine system, which is really important. And I'll outline that in a minute. So the hypothalamus is important when it comes to the endocrine system because it does control the release of hormones that provide us that stress response in the end. So the hypothalamus is like the boss of the pituitary gland. The pituitary gland is a major organ of the endocrine system. You can call it, quote unquote, the master gland. And with the pituitary gland, it stimulates the adrenal gland. The adrenal gland is found right above the kidneys, and it produces adrenaline. The amygdala is also really important when it comes to the stress response as well. It's almond shaped, an almond-shaped collection of nuclei, and it participates in emotional and species-typical behavior. So this makes sense when it comes to the stress response too, especially in cases of fear, right? If I'm seeing this like clown right at my window, I am going to be deathly afraid. I don't know about you. I don't like clowns. And I think I would be very afraid of a clown that is like staring at me outside my window. So I think my fear is valid. But taken together, my amygdala would be like, oh crap, danger. So the point is the amygdala is important, and I'm afraid of clowns. Neurotransmitters are also really important. With that dopamine, with dopamine, we know that dopamine is implicated in learning and movement. Dopamine is also important when it comes to the stress response because it regulates the HPA axis. I said regulate, but it helps it act within the feedback system. Serotonin is also really important. We know serotonin controls, but it's implicated in just about everything, such as mood, eating, arousal. And with the stress response, it co-regulates with dopamine when it comes to that stress response. So taken together, various parts of your body and even like the neurotransmitters are really important when it comes to the stress response. So you can imagine what's going to be happening with folks who are experiencing anxiety. Of note, unfortunately it's not up here, glutamate and GABA are really important when it comes to anxiety. While they aren't necessarily highlighted, and I'm sure there is research on glutamate and GABA in the stress response. When it comes to anxiety, remember glutamate is really important. Well, let me back up. When it comes to these two, these are the amino acid neurotransmitters. In particular, with when we think about glutamate and GABA, we can think about a gas pedal and brake, right? With GABA is like the brake. Glutamate is like the gas pedal. So GABA unexcites our brain. So it puts the brakes on our brain. It's like, stop right there, man. Glutamate is the gas for our brain. So it excites our brain. So taken together, neurotransmitters are really important. Dopamine and serotonin are really important in the stress response. Glutamate and GABA are really important when it comes to anxiety. All right, so physiological impact. So now we're going to talk about changes in the brain observed in folks with these different disorders. So when it comes to panic disorder, we do see some alterations in the brain. So what we have seen is a lower metabolism in the left inferior parietal lobe. And we see elevated glucose in these different areas. So when we think about folks with panic disorder, it makes sense that they're having these activations in these parts of their brain, because of all the different symptoms that we see, right? We also see decreased frontal lobe activity. With neurotransmitters, when it comes to GABA and glutamate, it's really interesting because we see a decrease in GABA concentrations, an increase in glutamate concentrations in folks with PD compared to folks who do not have PD. So taken together, if we're looking at it, a person who has PD, there's more push on the gas and little on the brake. We also see a decrease in serotonin concentrations and an increase in norepinephrine concentration. So earlier I mentioned norepinephrine as a hormone. It can also act as a neurotransmitter, depending on where it's impacting. So when we're looking at this as a whole, in this case, in folks with PD, we have seen an increase in neurotransmitters, an increase in norepinephrine in folks with PD. So taken together, with folks who have panic disorder, we do see alterations in their brain correlated with their increased worry and concern with having panic attacks. Social anxiety disorder, when it comes to brain regions, we do see an increase in amygdala activation, as well as an increase in subcortical, limbic, and lateral paralimbic activity. So Martin and colleagues, when they noted these specific increases with amygdala activation, it was in response to negative affective stimuli. So whenever participants were shown these faces with like difficult emotions, there was an increase in amygdala activation. And for folks with anticipation of speaking or public speaking, there was an increase in subcortical, limbic, and lateral paralimbic activity. So taken together, depending upon what is being presented to that person, you're going to see an increase in certain areas. We also see decreased activity in the anterior cingulate cortex and a decrease in the left hippocampus and right amygdala. We also see hyperactivity in the right prefrontal cortex. When it comes to neurotransmitters, we see an increased concentration of glutamate, as well as some serotonergic and dopaminergic abnormalities. So the study reported there wasn't a lot of serotonin transporter sites. With dopamine, what they did report disruption, but they didn't specify specifically if there were more or less dopamine, but they did say when it came to the transporters, the dopamine transporters in certain areas, there was a disruption, but they didn't specify specifically what that is. Generalized anxiety disorder, we do see an increased activity in the amygdala and an increase in volume of the amygdala as well. So with generalized anxiety disorder, what was found was that people tended to, not people, but there was a dysregulation of interconnectivity between different parts of the brain. So this included the superior temporal gyrus, the thalamus, and the prefrontal cortex. When it came to neurotransmitters, we saw a decrease in GABA, increase in glutamate, and a decrease in serotonin as well. Phobia. So I want to be clear, with looking for like studies on phobia, phobia isn't, it's not as widely researched, which is kind of odd, right? Given that it's one of the most common forms of anxiety disorder. So I just want to make note of that before I move forward. So brain regions, we do see, as you would suspect, exaggerated activations in the amygdala and the thalamus. We also see greater activation in the anterior cingulate cortex and the insular cortex too. OCD. So what research has suggested is that there are abnormalities in the thalamo-cortico-striatal loops. So with the striatum, the thalamus, the orbitofrontal cortex, and the anterior cingulate cortex. So specifically what they reported that basically there's like some, I don't know how else to say it because that's the only word coming to my mind, like abnormality with these specific brain regions. As far as neurotransmitters, with serotonin, we do see reduced serotonin concentrations. There was reduced serotonin transport availability. There was a suggestion that dopamine may be implicated in OCD. This study reported that antipsychotics, they did relieve some symptoms of folks with OCD. However, in other cases, the antipsychotics, they exacerbated the symptoms. So we're not really clear on dopamine in OCD. With glutamate, we see an increase in glutamate concentrations as well. All right, so PTSD. So there is like substantial research that does document changes in neurobiology in people with PTSD. So we're going to talk about the neurotransmitters first. So dopamine as an example. Dopamine there's like an increase in dopamine levels in folks with PTSD. And according to some research, it results in like the interference with the fear conditioning that is done through the mesolimbic system. Serotonin. Serotonin appears to compromise the anxiety effects. So with serotonin, we do see an increase in vigilance, startle responses, impulsivity, and memory intrusions. So it appears that a person is too aroused. So there'd be an increase in serotonin as a result. Glutamate, right? It's a high, I say high, but a very high concentration of glutamate is common in folks with PTSD. It may result in the derealization and dissociation symptoms that folks with PTSD experience. GABA. So we know that GABA excites the brain. So with GABA, we see this decrease in GABA activity, which does compromise like anxiolytic effects as well. Norepinephrine, there has been noted an increase in concentrations in norepinephrine, and this can result in an increase in arousal and startle response, as well as encoding of fear memories. So with PTSD, what we see, especially when we're looking at that stress response in folks with PTSD, the hippocampus is really important. We do see reduced hippocampal volume. So we see like folks with PTSD, there's smaller volumes that are associated with uh, the severity of trauma and memory impairments. So the smaller the volume, the more severe the impairments, or excuse me, the more severe the trauma, the smaller the volume, and as a result, greater. Hold on, I got that wrong. Let me repeat it. So with hippocampal volume, right? The smaller the hippocampus, the smaller the hippocampal volume, the more severe the memory impairments. Took me a while. With this decrease in hippocampus, some folks may suggest that it results in, not results, but it reflects like the toxic effects of repeated exposure to cortisol. The amygdala is also really important. We do see an increased activation in response to general emotional stimuli that isn't really associated with fear. With the prefrontal cortex, oops, there we go. We see decreased volumes of the frontal cortex as well as the reduced activation of the medial prefrontal cortex as well. So treatment. Basically what I'm gonna cover in this section is treatment. So I'm gonna talk about different therapies as well as medications in this section. So really what I'll cover is medication, therapies, and even other alternative treatments. So when it comes to anxiety and obsessive compulsive disorders, medication is provided. In some cases, in certain disorders, it is like the first thing that is like given. So I'll go over the different medications for different disorders. So for generalized anxiety disorders, TCAs and MOIs, in the beginning, they were like the first line of treatment. However, with some folks' concerns with TCAs and MAOIs, it's, as of right now, it's not like the first line of treatment, our first line of choice, excuse me. So SSRIs and SNRIs, for example, are the first line of choice for folks who are diagnosed with GAD. So these are the different types of medications that are prescribed. Some research suggests like antipsychotics, but the thing about it is some folks with metabolic syndromes would be concerned due to side effects of these antipsychotics. Anticonvulsants has also been implicated as well, but also still some concerns with like side effects as well. So with panic disorder, there are different, so what we see is MAOIs and, hold on, let me get to it. There you go. TCAs and MAOIs, but they're not recommended as first line of choice. instead SSRIs and SNRIs. So fluoxetine, paroxetine, and sertraline um, have been like have been like uh, have been helpful in treatment. For social anxiety disorder, SSRIs, specifically paroxetine and sertraline, are FDA approved. Venlafaxine, oh geez, the V word, it's also implicated. I say implicated, but also used for folks who experience SAD. It Before I go forward, MAOIs and reversible MAOIs, they have been considered, but they're not considered to be the first line of treatment, especially when we're thinking about folks with metabolic disorders. OCD. With OCD, interestingly enough, serotonergic tricyclic, tricyclic antidepressants, I say antidepressants, serotonergic tricyclics have been used in response to OCD. SSRIs have been prescribed to folks with OCD to help regulate the symptoms, and they are listed here. So when it comes to therapy, generalized anxiety disorder, so CBT, mindfulness-based cognitive therapy, has been found to demonstrate efficacy. With panic disorder therapy, go back. So panic disorder specifically, CBT has been used, but there's also some exposure therapy as well that has been implicated in, not implicated, but that has been that has demonstrated efficacy for folks with panic disorder. Specific phobia, so exposure-based therapies have been really, really helpful. In some cases, CBT, but when it comes to specific phobia, we tend to see that exposure-based therapies are like the most helpful. And it makes sense. You're exposing that person to their favorite stimuli, and as a result, you're helping that person work through their own stuff. With social anxiety disorder, let me go back. With social anxiety disorder, what has been found to be like really, really effective has been some exposure-based therapy as well as CBT. So taken together, when we're looking at folks with social anxiety disorder, providing them that exposure to their feared situations, or situations where, I say situations where, but the situations where they fear the most, really important. Also some social skills training as well has been really helpful. With OCD, what I found when you're comparing OCD to medication, people have responded more to the therapies compared to the medication, which is really interesting to me. If you think about it, well, let me talk about what therapies are really helpful. With OCD, CBT uh, has been really helpful. More of your behavioral based therapies, also exposure based. Um, given that uh, uh, folks are their thoughts and their behaviors are uh, both like interlinked, and during these exposure-based therapies, and even with CBT and some of these behavioral therapies, you get the client to uh, hone in on the cognitive dimensions as well as the behavioral stuff, and providing them ways to cope during, you know, I say cope during, but to address the maladaptive thoughts and the maladaptive behavior. Oops, there we go. ACT has also been helpful with folks with OCD. Really, folks are suggesting that there's the mindful piece of ACT, and just the acceptance of thoughts as being really important, are really helpful in folks with OCD. So as far as alternative methods, meditation has been used to work, but lifestyle modifications as well. So an increase in exercise and physical activity, avoidance of nicotine, caffeine, and alcohol. Oops, go back. So what I'm not suggesting is that a person only just use like meditation and changing up parts of their life as only methods of coping with these different disorders. Um, these can be really good if they're being used within other therapies. So with the lifestyle modification, right? So providing folks around psychoeducation, uh, around the benefits of physical activity and exercise when it comes to anxiety. Also with the use of like stimulants and even with alcohol, how that can facilitate anxiety related symptoms in these disorders. PTSD, we do see, hold on, there you go. SSRIs and SNRIs being prescribed, so sertraline and Benelax. When it comes to therapies, there's a lot of research that suggests that exposure therapy is really helpful for folks with PTSD, CBT as well. Cognitive processing therapy, or CPT. So just a little bit of background information on CPT. CBT is based on the information processing theory of PTSD, and it includes education, exposure, and cognitive components. And what has been found, interestingly, Resick and Schnick, in 1992, when he did the study with 19 women who were sexual assault survivors, they found that their symptoms improved significantly from pre to post treatment on PTSD and depressive measures, and they maintained improvements for 6 months compared to women who did not go through that same treatment. Narrative exposure therapy has also been helpful for folks with PTSD as well. It has demonstrated some efficacy as well. And then EMDR. EMDR basically focuses on perceptual components, on memory, and new links with adaptive information that is contained in other memory networks. So taken together with PTSD, there are different types of treatments that tend to work better. So when we're looking at it as a whole, um, with exposure therapies or exposure-based therapies, um, they're really helpful. CBT as well, uh, but I'm not saying one is better than the other. I'm just saying that certain therapies work well, but it's important to tailor that with your clients. So I talked about these different things. I've talked about different anxiety disorders. I talked about different treatments, not treatments, yes, I did. But I also talked about the physiological impact and involvement with with these disorders. And um, I think something that's really important for us to remember, especially as counseling psychologists, is that we want to make sure that so when it comes to anxiety disorders, certain disorders are more common than others, and uh, we have research to show that. The concerns about research on certain on treatments with certain disorders might be something for us to look into a little bit more. Um, so when we're looking at certain disorders, one of the disorders that get looked at the most is like PTSD, as well as with as well as folks with social anxiety disorder as well, and to some extent generalized anxiety disorder. But there are other disorders that aren't looked at as much compared to the others, such as like specific phobia, as an example. So I think when we think about something for us to think about as psychologists is uh, how can we, best help folks who are experiencing these symptoms from anxiety disorders, and at the same time, uh, advocate for more research in the areas of treatment or for treatment um, as well. So taken together, when we're looking at anxiety, anxiety can be really complicated. Um, we also want to make sure that um, we're putting into context for that person as well. What we don't want to do is pathologize a person's um, healthy response to certain stimuli, and I'm specifically referring to people with diverse backgrounds, so people of color, people and women of color, and folks with like lower SES, working class backgrounds, LGBT folks who are transgender. Um, so we want to make sure that we're providing them that space to express themselves, express their own concerns, and not over pathologize them as well. That's it.